Dr. Pravin K Goel. I was the head of cardiology at SDPGI for nearly 35 years, and now presently I am the director of interventional cardiology at Medanta Heart Institute, Lucknow. During this annual CSI, I was asked to talk on a subject, CTO intervention, the rationale for the same and the benefits from it. So, I have a passion for CTO intervention, as you all know, and CTO is chronic total occlusions which develop with arterial blockages over a long time, and this several times becomes one of the major reasons for asking for bypass surgery, because the CTO, if it cannot be done and one needs a complete revascularization, then bypass surgery is the only option. So, how I take this subject, this is an area which has a niche skill level. So, if we have the expertise for CTO intervention, then if I can open a CTO, then first thing is I can avoid a bypass surgery. So, that is one. Second, the CTO vessel, although it is chronically occluded, does produce ischemia, and there are patients with CTO vessels who will have continued angina related to that vessel, and opening that vessel by CTO intervention could relieve this angina, could improve the quality of life, could improve the work capacity of the patient. So, that is the second indication that it should be done, and that is all a class 2A indication as per the guidelines. Thirdly, we often believe that, well, the vessel is totally blocked, so you need viability studies. Now, I agree, viability studies are required provided there is wall motion abnormalities. If there are several situations where the vessel is occluded, but the LV is contracting normally, if it is contracting normally, then there is no issue of a viability study. The issue of reversible ischemia, well, you should document reversible ischemia in asymptomatic patients, but if the patient is symptomatic because of the CTO vessel, you could go ahead and do it, and this will relieve his symptoms. The only downside which has been said is that we do not see mortality benefit after a CTO intervention. Agreed, but the mortality benefit could only come if there is the stable, these patients largely are stable CAD, and stable CAD, the annual mortality say is only about 2%. So, to show a mortality reduction, we need large number of patients in a prospective trial, which is still not been possible to do, especially because the outcomes of a CTO intervention are not as predictable, which will vary on the operator experience. And last but not the least is, if I have a CTO vessel and in the unforeseen event of a remote MI in future, one vessel is already blocked, the second gets blocked in future, you have no source of alternate collateral supply, and the LV comes down and one could literally lose his life. So, an open CTO vessel, that is the open vessel hypothesis, will help us give a collateral source in that unforeseen event of a remote MI in future. So, all these things taken together, the current indication and the current guideline also says it is reasonable to do a CTO intervention in patients who are symptomatic, provided the expertise of the operator is reasonable or good, and he can give a positive risk benefit ratio to the patient. Thank you.